All right, class. This is Dr. Weaver again. I'm going to go ahead and talk to you about a portion of this chapter 50 in your Med Surg textbook. And this one shouldn't be as bad in terms of the time limit as either. I'm thinking maybe 45 minutes, if that. So it's not as bad, to be honest. So let me go ahead and start sharing. Let's see. Let's see what that looks like. Nope, not that one. Yeah. All right. As you guys can see here, well, you probably can't see it too well now. Let me do this. All right. All right. So you guys can possibly see where I wrote on the slide voiceover. So essentially slide 19 is where I'm going to begin. And I should be able to get to the end fairly quickly. I think ALS is probably, and also Guillain-Barré syndrome, it's probably the longer ones, but even they are not too bad. All right. So as we will likely discuss, of course, in class, you guys should know by now that we are dealing with diseases, disorders that relate to the peripheral nervous system. So again, what that essentially means is that these are disorders that exclude the brain and the spinal cord. Remember, those are central nervous system disorders, but these are disorders that affect the peripheral nerves, if you will, even the cranial nerves. Even though it kind of sounds a bit contradictory. Being that the nerves are in the cranial area, they're actually part of the peripheral nerves and not the central nervous system. All right. So let me go ahead and open this up a little more. All right. So there's a condition called Lou Gehrig's disease, or amyotrophic lateral sclerosis. All right. Now, this is a progressive degenerative condition that affects the motor neurons responsible for the control of voluntary muscles. And so remember, so you have sensory nerves, but you also have motor nerves or neurons. The sensory nerves is what it captures or experiences a sensation. All right, it's kind of like you touch a hot stove, right? And so you feel the heat, the pain, and what have you. And when you jerk your hand back, that's a motor response. Right. So think about it in those terms. And so this is a condition that affects the motor neurons. And so we already know, just thinking about that, movement is going to be compromised. Right. Now, in the brain and spinal cord, we have upper and lower motor neurons. They begin to degenerate, right? And they form scar tissue or they die. When those motor neurons or those neurons, when they are blocked, excuse me, when they begin to die or scar tissue develops, then that nerve transmission cannot move along the nerves normally. So you guys know that the nerve impulses starts at a certain point and they travel from one nerve or neuron to the next. Well, when you develop scar tissue, or the neurons die, then you don't get nerve transmission, and of course, you don't get movement. All right, and even sensation is going to be compromised as well. Now, without stimulation, our muscles they will atrophy, and then our muscles will also lose muscle strength, and also coordination decreases as well. Now, as the disease progresses, more muscle groups are going to be impacted, especially muscles of respirations, muscles of swallowing. So, as you can tell, just listening to that aspect of the pathophysiology of this disease, we know that these patients will have the inability to swallow, so aspiration can be a problem. Nutritional deficits might be an issue, and of course, these patients can. They can have a lot of problems and even die due to respiratory failure. All right. Now, the heart and the GI tract are controlled involuntarily. Remember, this disease affects the voluntary muscles, but it does not affect or impact the heart and the GI tract because these are controlled involuntarily, especially by the parasympathetic nervous system, and they're not affected by ALS. Right? ALS is the Lou Gehrig's well, actually, amyotrophic lateral sclerosis. Excuse me. I think Lou Gehrig was a baseball player, and they had this movie that came on years ago that depicted his life and when he was diagnosed with this disorder, or it could be football. I'm not sure. I don't quite remember. Anyway, this condition does not affect thinking and reasoning either. So that's just more the central nervous system. All right. Now, ALS can occur at any age, but typically it does not appear until adulthood. The cause of this condition is not known, but of course, there is some genetic a component. Smoking and other toxic toxins also appear to be an increased risk for this condition. All right. Now, symptoms are vague early on in the course of this disease. Some of your primary symptoms are going to include progressive muscle weakness and decreased coordination. And this can begin in the arms and the legs or muscles of speech as well as swallowing. All right. So all of these are peripheral in nature, peripheral nerves. You may also see atrophy of muscles because they're not really being that motor part of the neurons are dysfunctional. You might see fasciculations, which means muscular twitching. Muscle spasms can cause pain. Difficulty with chewing or swallowing can place the patient at risk of a choking as well as aspiration. And this is, of course, as the disease does progress. Right. These patients also experience inappropriate emotional outbursts. They may start laughing and crying. Speech also becomes difficult. These patients also lose bladder and bowel functions, or rather, I'm sorry, bladder and bowel functions do remain intact. But these patients will are likely to experience constipation and also urinary urgency, hesitancy, as well as frequency. Remember, the parasympathetic system controls our bladder and bowel functions. It's an involuntary function. Now, later in the disease, these patients, their communication ability is going to be limited to just basically moving or blinking the eye in response to questions. And so you might say blink one time for yes, blink two times for no. These patients may have the pulmonary function system will become severely compromised to the point that they might need to be intubated and placed on a ventilator to help them breathe. Other complications can include extreme malnutrition because they have these problems with swallowing, falls, right, the muscular weakness and what have you, pulmonary emboli because they're so immobile. Blood clots typically can form, usually in the lower limbs, and then they break off and they move to the lungs. And also, it can result in heart failure. Now, ALS eventually leads to death usually from respiratory complications such as atelectasis, which means the collapse of the alveoli in the lungs. Also, respiratory failure along with pneumonia can occur. All right. Take a look at the diagnostic tests. When we start thinking about some of these symptoms, many other diseases, disorders, they share some of those similar signs and symptoms. So in this particular case, they'll be ruling out things and ruling it in others and whatnot. So part of it is to do a history and physical. So just having this discussion with the patients and them sharing their experiences can, kind of alert the provider, the healthcare team that, this is the direction we're going. This is what it seems like the issues are. So the diagnosis is made based on clinical symptoms. There are also tests on the cerebral spinal fluid because you typically will find certain proteins in the cerebral spinal fluid that shouldn't be there. These patients might have an EEG, which can determine electrical activity in the brain. Nerve biopsy may be done, so they might be able to detect disease in the nerves itself. They also might do a nerve conduction velocity study. And this test allows them to determine if the patient has normal nerve impulses. Remember what I told you before, the nerve or the impulse starts at some point in the peripheral nervous system in particular, and then it travels to whatever muscle, in this case, if you will, maybe the arms or the legs and so forth. And so if those neurons are diseased or scarred, if you will, from disease, then transmission of those impulses are going to be compromised. EMGs may also be done to rule out other conditions. Blood enzymes can be increased as a result of muscle atrophy. And basically what happens is when the muscles undergo atrophy, especially due to them not being used or if they're injured or certain medications that patients might be taking, the muscle fibers, they break down. Right, and this breakdown can release the cellular components of the muscles, including enzymes, and it ends up in the bloodstream. And so there are lab tests that can be taken to detect this issue. Right. There's no cure for ALS. Treatments are essentially palliative, just to provide comfort for this patient. Goals of treatment are aimed at maintaining function for as long as possible, providing emotional support to the patient as well as the family. These patients might be placed on Robenol because it can help decrease saliva production. So it means that there's a decreased risk of aspiration. They may be placed on carbamazepine or phenytoin. These are seizure medications, and they give this to control muscle cramps. Not seizures, but these drugs also help to control muscle cramps. Baclofen may also be used for spasms. Those are typically for muscle spasms because they do cause pain in these patients. Rilotec is a drug that slows the progression of the disease, and also it can prolong the patient's life by at least 3 to 4 months. So not very long, but it can prolong their lives. There's a substance in the body called glutamate that causes damage to the motor neurons. These patients are given a medication called Radicava, and this reduces the glutamate, again, which destroys motor nerves. And so this can slow the decline of in function for the patient. Now, some of the non-pharmacological measures, such as PT, or physical therapy, massage, position changes, and other diversional activities can also help control the patient's pain. These patients may have to be placed on enteral feedings, and so a gastrostomy tube may have to be placed in order to help with nutrition. We want to also prevent infection in these patients, such as pneumonia and UTIs, is going to be vital. Meticulous skin care minimizes the incidence of pressure injuries. Remember, these patients can't really move very well, and so they are at risk for pressure ulcers. PT, OT, and ST, speech therapy, in other words, therapies can allow the patient to maximize what little function they have as long as possible. Therapy also decrease the occurrence of complications such as aspirations, falls, and as well as contractures. These therapies can prevent these issues. Um, and as the disease progresses, mechanical ventilation is likely to be needed because the patient is not able to breathe on their own. Patients may choose supportive hospice. They may choose to go in the hospice instead of life prolonging mechanical ventilation. So they have to make sure they, have a living will, so they can direct family members of what kind of care they desire. Patients with speech problems may benefit, of course, from alternative communications. They have a variety of devices out there. Most involve laptop computers that the patient can use to type words or symbols in order to generate speech. Supportive groups and counseling provide emotional support for the family and the patient, or the patient and family as well. So that's really important. Take a look at the patient education, providing them information about support groups, which can come from your social worker, importance of avoiding infection because you don't want to make the problem worse than what it is, and also teaching the family how to provide care to these patients will be important as well. And a request to to a palliative care specialist would be really important again for advanced directives. All right, so that ends that particular disease system. The other one of this, the next one rather, is what we call Guillain-Barré syndrome. I used to think that was Guillain-Barré syndrome, but I discovered that it was Guillain-Barré syndrome. As far as the pathophysiology and the incidence and prevalence of this condition, it is a rare neuromuscular disease affecting only one in every 100,000 persons. Both men and women are impacted by this condition equally. This condition can occur between the ages of 30 and 50. Um, Guillain-Barré syndrome is an inflammatory disorder that is characterized by abrupt onset of symmetrical paresis or weakness. Right? It's abrupt in nature. It happens fairly quickly, and then it progresses from weakness to paralysis. The myelin sheath of the spinal and cranial nerves is destroyed by a diffuse inflammatory reaction. So there's some kind of infection that is going on, and it is this diffuse inflammation that is affecting what we call the myelin sheath. And I'll show you what that looks like. As a matter of fact, let me see. Um, I'm going to stop sharing for a moment just to quickly show you what the myelin sheath looks like. I think I just have to reshare again because it may not pick it up. So let me, myelin sheath. All right. So, so what we're looking at here, all right. So this is the nerve itself, the gold-looking color. That's the nerve itself, right? And so what protects these nerves, or what we call the axon, is this material called myelin. We call it myelin sheath. You see how it covers the nerve? It's actually protecting the nerve, right? It insulates the nerve and what have you. And so what happens is when this inflammatory situation occurs in these patients, this sheath is basically destroyed or eaten away, basically. And so then you essentially see just the yellow of the gold-looking part here, right, without the myelin. So you say, well, what is the problem with that? So as long as these patients have this myelin sheath that is covering the nerves, it enables nerve impulses to travel from here to the next one that looks like this, and to the next one, and to the next one. See, this is a long line of neurons that, let's say, if it goes from the spine to your arm, and so you have this series of nerves that that branches out to, let's say, an extremity. And so when you have this myelin sheath that is protecting the nerve itself, then the impulses travel at a normal rate. When the myelin sheath is destroyed, those impulses are going to be impaired. And of course, these patients, they will experience a kind of weakness and even paralysis to that point. So the myelin sheath is extremely important in this peripheral our nerves. All right. All right. So let me go back and share again. I think that's it. All right. Uh-oh. Right. Now, the peripheral nerves are also infiltrated by lymphocytes. Remember, lymphocytes are part of the immune system, and so they destroy viruses and bacteria and anything it can destroy that is trying to harm the body. When the peripheral nerves are infiltrated by these lymphocytes, this is when inflammation occurs and also edema occurs. Now, when we talk about segmental demyelinization, basically the nerves are demyelinated. In other words, the myelin sheath is destroyed. All right, certain portions of the myelin is destroyed from those nerves I just showed you. And this is going to cause atrophy of those axons or the nerve itself. And this results in slowed or blocked nerve conduction. And so those impulses, they just don't travel at a rate that is normal. Right. We also have what is called segmental. I'm sorry, I said that. So typically, this demyelinization, this destruction of the myelin that protects the nerve, begins in the most distal nerves, and then it moves in a symmetrical fashion towards more proximal towards the spine, if you will. All right. Now, remyelinization, meaning the those peripheral nerves that tend to or can develop the sheath around the nerves at some point, but it happens very slowly. And it does occur in a descending pattern. So it starts more proximal, but then it descends towards the distal. All right. And of course, the symptoms will improve when the remyelinization occurs. Hopefully that makes sense. Now, there are four recognized variants or types of this Guillain-Barré syndrome, but we're only going to discuss the most common type, and that is the ascending Guillain-Barré syndrome. Right. Now, it is characterized by a progressive weakness and numbness that begins in the legs and ascends to the body itself. That's that when we talk about it starts at the most distal nerve and then travels or ascends. And so it's traveling towards the body, that weakness, if you will. Numbness tends to be mild, but muscle weakness usually will likely progress to paralysis at some point. The paralysis can ascend all the way to the cranial nerves. You know, the cranial nerves controls things like eye movement, tongue movement. You can, shrug your shoulders and the facial expressions that we make, and whether you're frowning or you're smiling, and all these different nerves, these cranial nerves. There's 12 of them. And so it can affect the cranial nerves, and so you will see symptoms that impact these patients uh, in that respect. All right. Um, so the paralysis can ascend all the way to the cranial nerves, or stop between the legs and the head. Now, deep tendon reflexes are either depressed or absent. This is when they take the reflex hammer and they tap you on the knee, and you know how your knee moves or your leg moves. Well, that can be depressed, so it may not move, or it may move a little. It reacts a little, or there's no reflex at all. These patients, at some point, because of the paralysis, especially of the muscles, the motor neurons, can require mechanical ventilation, and and this occurs in about 17 to 30% patients with this condition. So, which is a pretty decent number when you think about it. This condition is believed to result from an autoimmune response to a viral infection or certain vaccines, even. That's why some people they don't want vaccinations and what have you because of how it may affect the neurological system. But the exact cause is not quite known. Usually, the viral illness affects the respiratory. It's a respiratory or GI infection, and it occurs 2 weeks before the onset of these neurological symptoms of Guillain-Barré. Now, the most common organism with Guillain-Barré is what we call Campylobacter jejuni, and this is a common cause of gastroenteritis. Remember, it's a viral infection of the GI system along with the respiratory system. Now, the signs and symptoms are divided into three different stages. The first stage is the onset of symptoms. These patients, the first stage starts with an onset of symptoms and lasts until the progression of the symptoms stops. Now, this stage can last from 24 hours all the way to 3 weeks. It is characterized by it is abrupt. It has a rapid onset of muscle weakness and paralysis with little or no muscle atrophy. Now, patients with ascending Guillain-Barré may gradually notice the reduced ability to take deep breaths or have conversations because the cranial nerves are impacted, and they may feel shortness of breath. Now, these patients are terrified because they will not be able to breathe, and they may require intubation as well as artificial ventilation. Now, the autonomic nervous system is often affected by Guillain-Barré. Patients experience unstable blood pressure, the cardiac arrhythmias, urinary retention, as well as paralytic ileus. Remember, that's when the intestines are paralyzed; they don't have peristalsis. All right. Patients report of discomfort from annoying. They may have numbness and cramping to severe pain. The discomfort is exacerbated by the patient's inability to move voluntarily. And so that has a host of other issues in and of itself. Now, stage two is what we call the plateau stage. The second stage, so this is when symptoms are most severe, but the progression has now stopped. It's no longer getting worse. It can last from 2 to 14 days, and the patient may become discouraged if no improvement is evident. And the last stage is what we refer to as the recovery stage. This is when axonal is basically the nerve itself, and remyelinization. Remember that covering that sheath, that material that covers the nerve, can occur during the third stage and recovery. Now, this stage may last a lot longer, six to 24 months, and the symptoms slowly improve. Most patients with Guillain-Barré recover in a few months to a year, and a few patients experience chronic disability. All right. Now, these patients, they might complications can include, of course, respiratory failure, infection, as well as depression. It is important to discuss the possible need for intubation early in the patient's illness so that they can decide. Now, the decision to intubate in Guillain-Barré is different from other peripheral nervous system disorders because Guillain-Barré patients are expected to recover. They usually can recover. It is important to be vigilant in monitoring the patient's pulse oximetry, which determines oxygenation, the respiratory rate, the depth of respirations, and also shortness of breath in order to predict the need for interventions and maintain the patient's safety. And so they might really need that ventilator. Now, these patients are also prone to pneumonias as well as UTIs. So maintaining infection control practices and also maintaining the patient's nutritional status can help decrease the likelihood of these issues. Immobility to problems such as skin breakdown, pulmonary embolus because they're not moving and so they develop blood clots in the lower limbs, which can move to the lungs. Um, Deep vein thrombosis, and this is where the clots usually form when patients are immobile. And also muscle atrophy can occur. These patients with GBS or Guillain-Barré have little time to adjust to their illness and deterioration because it is abrupt. Remember, the onset is abrupt. They often fear they would not recover function. So that calm, supportive reassurance is going to be vital as you manage these patients. Take a look at the diagnostic test. A lumbar puncture is performed to, or what we call an LP, is performed to obtain cerebrospinal fluid. The cerebrospinal fluid analysis shows a normal cell count, but it has an elevated protein level that shouldn't be there. An electromyogram and a nerve conduction study test are also done to evaluate the nerve's function. Basically, you're testing nerve conduction impulse movement. Pulmonary function testing can help and confirm that impending respiratory problems are likely, and so the patient might have to be intubated as a result. Now, during the initial stages, patients are partially or completely dependent on all of their needs from family and clinicians. They're frightened. They are anxious. And these patients will need oxygen and possibly mechanical ventilation at some point. There is a therapy that is referred to as plasma exchange. And so this patient's blood goes through this device, right? The plasma exchange may be used to remove the patient's plasma and replace it with fresh plasma because the fresh plasma may not have those how can I say it? They're basically trying to remove, I guess, like antigens, if you will, or whatever is causing these symptoms or that has caused the inflammation to occur. They're trying to remove that from the body, right? So they're replacing the patient with fresh plasma. And this procedure is thought to lessen the body's immune response. All right. So the body does not react with less strength, if you will. The immune system won't try to destroy its own because remember, it is an autoimmune disorder as well. So it will lessen the immune response to the body. Immunoglobulin therapy may also help reduce the severity of the disease because you're trying to enhance the immune system. Supportive interventions such as anticoagulants like heparin or Lovenox might be used to prevent DVTs, hence also hoping to decrease pulmonary embolus. Analgesics for pain may also be warranted. And intensive rehabilitation helps the patient regain function during the recovery phase as well. As far as nursing care, we monitor the vital capacity. This is how we monitor the lungs. We do a pulmonary function test to determine if the patient has that their breathing is not compromised. Arterial blood gases rather can tell us if the patient is having respiratory compromise. We also provide supportive care. Remember, we're basically treating these different symptoms like fevers or whatnot. We give an antipyretic. Pain. We treat the pain. They may have whatever the issues are. We're providing supportive care essentially. All right. Nutrition. We maintain nutrition. That may be in the form of a feeding tube. We also want to provide a way of communication for these patients. It may just be just as simple as the eye blinking. and also provide some diversional activity for these patients. We also want to monitor the patient's gag, reflex, corneal and swallowing reflexes to determine whether safety measures are needed to prevent aspiration or injury to the eyes. We sometimes put patches on these patients' eyes or we tape them shut because they cannot move. They can't close their eyes, and so the cornea becomes dry. So we may have to put eye drops in, um, and and again, we protect the cornea because we don't want any like abrasions to occur. We don't want aspiration to occur. And be prepared to reinforce teaching provided to the patient and the family about the disease and to help them. Take a look at table 50.3. It does summarize and compares myasthenia, or rather, multiple sclerosis versus myasthenia gravis, ALS versus Guillain-Barré syndrome. And so that would be a good comparison for you to see, just in case, or try to prevent you from getting confused and what have you. All right. Let's see. So the next one topic is post-polio syndrome. Polio is essentially eradicated from the United States, but those who have acquired it from years ago, these survivors of 20 to 40 years ago, after they've recovered from the infection, they may develop this condition. Up to 40% of patients who have polio develop post-polio syndrome. Now, that's quite a bit. It's like half of the people, right? Signs and symptoms of post-polio syndrome involves further weakening of the muscles that were affected with the first polio infection. Symptoms can range from fatigue to progressive muscle weakness, as well as atrophy. Sleeping problems, joint pain, scoliosis, respiratory compromise can also occur with these patients. Some people may suffer great debilitation, and others have fewer problems. The diagnosis is made based on the patient's history and also ruling out other disorders. So you may have to rule out the Guillain-Barré and the multiple sclerosis and so forth before they conclude, based on history, that the likely culprit is post-polio syndrome. No interventions have really been found to be effective in this at this time. However, physical therapy can help the patient increase their exercise tolerance, right? And also occupational therapists can help the patient with assistive devices in order to conserve their energy. Take a look at the appropriate nursing diagnosis for these neuromuscular disorders, ineffective airway clearance, impaired physical mobility, as well as impaired verbal communication. And we pretty much have gone over what this disease does. Some of these diseases, what they do to the airway, what they do physically to these patients, as well as the inability to communicate. The next condition is restless leg syndrome. This is an uncomfortable sensation in the legs, causing the patient to constantly feel the need or the urge to move the legs. And it typically, unfortunately, occurs at rest or at nighttime. So these patients don't get a lot of rest. Now, this condition is related to the imbalance of dopamine and serotonin in the brain and may have a hereditary component as well. Some medications can aggravate restless leg syndrome. Patients with chronic conditions such as chronic kidney failure or kidney failure, iron deficiencies and diabetes, patients with Parkinson's and peripheral neuropathy may also develop this condition. Now, symptoms of restless leg syndrome can improve as these medications are discontinued. And so we may have to discontinue the medications and then, of course, treat whatever their illness is, and that might provide some relief. So take a look at some of the signs and symptoms here. The patient have this feelings of creepy, it's like a crawling sensation in the lower limbs. They may also experience throbbing or like something is pulling, and this pulling sensation in the lower extremities. They may also experience pins and needles sensation. And they experience daytime fatigue as well as insomnia because, again, as I said, this typically happens at rest or at nighttime, and so it's difficult for them to sleep, and so they may have a problem staying up at nighttime. And so sleep deprivation can impact their work performance as well as their ADLs. Men and women are affected of all ages by this condition. The incidence in women is twice that of men, of course. People are often report these symptoms to the healthcare provider as they believe their symptoms will not be taken, or they may not. They often fail to report this information to the physician because they don't feel like their concerns will be addressed. No specific tests exist to diagnose this condition. It's more subjective, comes from the patient's reporting of these symptoms. The healthcare provider will order maybe blood tests, for example, iron deficiency, and may test to rule out other disorders. Patients should be asked about their medication history, whether family members have similar symptoms, or whether they experience daytime sleepiness. All right. Pretty straightforward when you think about it. As far as therapeutic interventions, these patients, if you application of heat and cold may be well, as far as supportive care may be helpful. Massaging the legs, be careful about that, especially if they um, um, have a condition where they're immobile and they may have developed blood clots in their lower limbs or DVTs, deep vein thrombosis. And then, of course, you're massaging the lower limbs and it can actually cause the blood clot to break off and travel towards some of your vital organs. Warm baths may be helpful. Medication to control the symptoms. Some of those medications are Maripex, Requip, and Nupro. They may be ordered for moderate to severe restless leg syndrome in order to increase the dopamine levels that are possibly deficient. Opioids, anticonvulsant medications, benzodiazepines may be prescribed when other therapies are ineffective. Let's see. Some lifestyle modifications, stop smoking, right? Regular sleep schedules, alcohol avoidance, as well as exercise routines may be helpful for these patients. Another condition we will talk about is a couple of conditions that involve the cranial nerve disorders, your trigeminal neuropathy, as well as Bell's palsy, which I've actually had the latter one before. Cranial nerves are are the peripheral nerves of the brain. It's not a part of the central nervous system, but they are part of the brain, but they refer to as the peripheral. There are 12 pairs of cranial nerves that innervate areas, including, or they interact, if you will, certain areas of the head, the neck, and special sensory structures. And you can look at more of that in chapter 48. Cranial nerve problems are classified as peripheral neuropathies. Um, disorders can affect the sensory, this disorder can affect the sensory. Remember, that's what they feel, motor, how the muscles react, or both branches of a single nerve. Causes of cranial nerve disorders might include tumors, infections, inflammation, trauma, and some unknown causes. Two common, and of course, the two main ones that we discuss are what you see here, the trigeminal neuropathy and Bell's palsy. Kind of getting there, folks. The pathophysiology of trigeminal neuralgia, sometimes also called tic-douloureux, involves the fifth cranial trigeminal nerve. This nerve has three branches that include both sensory and motor function. All right. The branches innervate areas or it affects areas such as the face, including the forehead, the nose, the cheek, the gum, as well as the jaw. Tic-douloureux, or excuse me, trigeminal neuralgia affects only the sensory portion of the nerve. Right. Irritation or chronic compression of the nerve is suspected to cause the symptoms. This disorder is more common in women and usually begins about the age of 50 to 60. And this is an example of the trigeminal nerve, and this is how the nerves they innervate or they affect these portions of the face. All right, so it may even affect this person's ability to smile or to frown, and so forth. All right, signs and symptoms. Um, this condition causes recurring episodes of intense pain, described as a sudden. The onset is sudden. They have jabbing, burning, or knife-like sensations. Episodes of pain begin and end suddenly, lasting a few seconds to also minutes. The attack occurs in clusters from a few times a year to up to hundreds of times daily. Pain felt in the skin on one is pain is felt in the skin on one side of the face. A slight touch, even a cold breeze or talking or chewing can trigger an attack, a pain. The areas of the face where pain occurs are referred to as trigger zones. Right. Areas affected include the lips, the upper and lower gums, cheeks, forehead, or the side of the nose. Sleep provides a period of relief from the pain. So these patients may sleep a lot in order to avoid the pain attacks. They may also refrain from activities such as talking, face washing, teeth brushing, shaving, and eating to prevent this pain. So you can imagine what this looks like for these patients. Frequent blinking and tearing of the eye on the affected side can also occur. The diagnosis is made by history and physical, so we have to, examine these folks and also get their version of, what is occurring. A CT scan as well as MRIs can also determine or tell us something that is going on with this patient, and also observation of an attack that may occur in your presence. As far as therapeutic interventions, the initial management includes Tegretol and Oxtellar XR to reduce transmission of pain nerve impulses. So you're trying to reduce the impulses. Usually we want pain impulses, or rather impulses to travel, but we want to block the pain. Drop some of these, not drop, block some of these impulses in order to reduce the pain that these patients experience. Commonly administered analgesics and opioids are typically not effective in managing the sharp and intense pain. This is a different kind of pain, and so this is why some of these seizure type of medications they actually are more effective against what we call neuropathic type of pain. So it's not the throbbing per se, throbbing, sharp, those types of pains that opioids are usually effective against. In other words, or it can be sharp pain with this condition, but neuropathic pain is just different. It's different from your usual pain pathways that causes discomfort in your patients. If medications are ineffective, microvascular decompression may be done to relieve compression on the nerve. So if something, maybe like a tumor or some other structure is pressing on the nerve, they can decompress that area, which would provide some relief. Other methods such as radiation, injections, or heat may be used to destroy the sensory portion of the trigeminal nerve. So you're just basically trying to destroy the nerve so that you won't, the patient won't experience the pain. Unfortunately, these interventions, this destruction of the trigeminal nerve, would cause the patient to have varying degrees of numbness and are supported by only limited evidence. Complementary and alternative therapies such as Botox, injections, acupuncture, electrical stimulation, and also nutritional therapy may also or has been used in varying with varying success. So it can help. The patient would need to learn to protect anesthetized areas of the face after nerve procedures. Um, because if it's anesthetized and they don't have any feelings, and so they have to be cognizant of the fact that there can be some injury, something that can occur that can cause injury to an anesthetized area, or something you don't want to occur. Um, if corneal sensation is lost, not Googles, but goggles and sunglasses may be used as needed to protect the affected eye. Also, an eye patch may be needed at night to prevent injury during sleep, and also artificial tears may be needed to prevent corneal damage. All right, so the next one is Bell's palsy. Bell's palsy. This affects cranial nerve 7, one of the peripheral nerves. This nerve becomes inflamed and also edematous, interrupting nerve impulses. This condition is also thought to arise from nerve trauma from a viral infection such as herpes simplex, most common. Also can occur from herpes zoster, influenza B, or Epstein-Barr. These patients have loss of motor. Remember, trigeminal is more sensory, but Bell's palsy is more motor. So these patients do lose motor control. That typically occurs on one side of the face. Bilateral facial palsy occurs rarely. All right, so it rarely occurs, affects both sides. It's usually one-sided. Contracture of facial muscles can occur if recovery is slow. So that disuse of the facial muscles can cause it to contracture. Men and women are affected equally. This condition is more common in women in the third trimester of pregnancy. People with immune disorders such as HIV and people with diabetes can develop this condition as well. And it occurs in all ages, including children. All right. And sometimes the etiology is just not known. Right. Now, the onset of symptoms may be sudden or progress over a 2 to 5 day period. Pain behind the ear may precede the onset of facial paralysis. Other vague initial symptoms are dry eyes or a tingling around the lips with progression to more recognized symptoms of Bell's palsy. The patient may be unable to close the eyelid. They can't wrinkle. If you command them to wrinkle the forehead, they won't be able to do it because remember, the motor function is compromised. They won't be able to smile or raise the eyebrow or even close the lips effectively. The mouth is also pulled towards the unaffected side, and it almost looks like the patient has a stroke. All right. Drooling of saliva occurs, and the affected eye has constant tearing. Right. Patients not even able to close their mouth. They can't even drink from a straw. Sense of taste is lost over the anterior 2/3 of the tongue, and speech difficulties occur as well. Most patients recover within about 6 months, though. I forget how long it took me, but it was very distressing, to say the least. These patients cannot blink. I think I said that. Well, yeah, they can't blink, and all the rest of those symptoms. See how they look here? Looks like a facial drooping, and so it may appear that they have had a stroke, but it's not really a stroke. And it's cranial nerve 7 affecting the motor neurons. Diagnostic tests, history and physical, electromyogram, and also rule out a stroke because that's what it looks like. These patients may even have to have an MRI to rule out multiple sclerosis. When I had mine, that was part of the standard of care, was that they do an MRI of the brain. Prevention of complications is the goal of treatment. Prednisone may be given over 7 to 10 days to decrease inflammation. Antiviral drugs such as acyclovir may be used in combination with the prednisone in more severe cases. Remember, this is more of a viral, or thought to be a more viral cause. Eye drops to provide artificial tears and eye protection are needed if the eyelids do not close completely, especially at nighttime. Analgesics are given for pain. Most heat and gentle massage to the face and ear can ease the pain. And a facial sling may be used to aid in eating and support of facial muscles. I'll tell you one thing: just massaging your face while this condition is present, I think helps stimulate those muscles and kind of aids to recovery a little faster, in my opinion. Take a look at the different nursing diagnosis, acute pain, imbalance nutrition, and also risk for eye injury to the eyes because of Bell's palsy. And I did provide you with some information about these different nursing diagnosis. So I'm going to let you guys go ahead and take a look at that in my notes. Fairly straightforward information. And actually, the rest of this is just the NCLEX exercises. And so, if you guys want to go ahead and do those, that's fine. And um, I'm going to end this presentation. And that one lasted for 56 minutes. You can probably listen to it in 30 minutes or so. If you kind of speed up um, the video on YouTube. All right, so that's it. I will go ahead and end it here, and I will see you guys hopefully soon. Thank you.